Hello, I am Dr. John Roshan and I work as an electrophysiologist in CMC Hospital, Vellore. Today I am going to be speaking to you about cardiac pacemakers. So this brings us into the discussion as to who is an electrophysiologist. So an electrophysiologist is basically a cardiologist who has done training in the electrical system of the heart. So when you build a house, the house has got water supply and current supply. If there's a problem with the water supply in your house, you're not getting water, then you will call a plumber to make that corrected. In the same way, if there is a problem with electric current not reaching your house, then you will call an electrician. The heart has got blood supply and current supply. So when the blood supply has problems with it or there's a block, then you need to call the plumber who does the angiogram and the angioplasty. On the contrary, if there's a problem with the electrical supply in the heart, then you need to call an electrician, and an electrician for the heart is known as an electrophysiologist. So today I'm going to be briefly covering for you what a pacemaker is and when we need to put a pacemaker for any given individual. Besides this, we will also briefly look at the procedure by which a pacemaker is done and what are the likely complications, what are the instructions that somebody needs to know after the pacemaker is implanted, and with regards to his follow-up thereafter. So here you see a picture of the human heart, and in this picture I have shown for you there are two chambers above. These two chambers above are known as the atria, and these two chambers below are known as the ventricles. So the atria push blood to the ventricles and the ventricles thereafter push blood outside. The left ventricle pumps blood to the entire human body. Now, for the heart to do its job, which is basically it works as a pump, just like how you have pumps in the field which pump water into the field, same way the heart pumps blood to the whole body. And for the pump to work, you need a source of energy, and the source of energy is electricity. So electric current is produced in the heart over here, and this point is known as the sinoatrial node or the SA node. So this is like the principle of the heart which produces current, and the current from there comes down to this point, which is at the midpoint of the two upper chambers and the two lower chambers. So this is like a junction, and this place is called as the AV node. So you have the sinoatrial node, which is where current is produced in the heart, which is otherwise in short form called SA node, and current thereafter travels to this point, which is known as the AV node. From here, the current travels down through a specialized wire, and this is known as the bundle of His, which then divides into a right branch and a left branch. The left-sided branch thereafter divides into one branch which goes up and another branch which goes down. So these branches divide into smaller and smaller branches so that every single point in the heart gets electric current at the same time. So when the switch over here goes on, or the sinoatrial node which produces the current is taken by wires to every single part of the heart. Once the muscles of the heart get the electric current, they will contract and send blood to the whole body. So this is how the normal heart works. As people get old, it is possible that the place where current is produced, that place doesn't produce current properly, doesn't produce current at the rate at which it is supposed to be produced. So when the pulses of current are not produced at the appropriate rate, the heart rate will become slow. So I said that this point where current is produced is called as the sinoatrial node, and when that doesn't do its job, in other words, the sinoatrial node or the principle of the heart has become sick and goes on leave, then that would be known as a sick sinus syndrome. So when somebody has a sick sinus syndrome, or the place where current is produced is not produced fast enough, then the heart rate becomes slow, and because the heart rate is slow, the body doesn't get enough blood and the person starts to feel weak and he can even faint. So one reason for an electrical problem in the heart is if you have the sinoatrial node not producing current at the rate at which it is supposed to produce. Now, the other place where you can have a problem is in the distribution of current. So you can have a problem with the production of current and you can have a problem with the distribution of current. So the current which is produced there comes down through the AV node through these various specialized wires and travel to every part of the heart. There is a possibility that you can have a break in these wires, and these breaks in the wires can happen anywhere. It can happen here, it can happen here, it can happen here, it can happen here. You can have breaks anywhere in the way the current travels down. And when there's a problem with current distribution, that is another situation where the person will have inadequate current coming, so the heart doesn't contract and doesn't pump blood. And when it doesn't pump blood, all parts of the body depend on the blood that is pumped by the heart. And so the person can either feel weak or can feel faint. So we will now start talking about the normal conduction system, which I just explained to you. So as you can see, current is produced in the sinoatrial node. It makes the two atria contract, then comes down to the AV node and then the other wires to activate the entire heart. And that's how the heart contracts. So you can see the same thing happening again, the current coming through the SA node, then making the two atria contract, and then goes down the AV node and the specialized wires, making the ventricles contract. So as you can clearly make out, the first what happens is the SA node depolarizes, then the two atria depolarize, then it comes down the AV node, the specialized wires, and then goes down to activating the two ventricles, and the ventricles also depolarize. In other words, they get the electric current and they contract thereafter. So this is what we just discussed was the normal conduction system. So what's important to notice is that first current goes to the two top chambers, which are the atria, and after that it goes down to the two bottom chambers, making the ventricles contract, and then finally the two ventricles will relax after their contraction so that they can again fill with blood, and once they fill with enough blood, then they will contract again to send the blood out. So this, as you can see, is how a normal ECG looks, which is basically a recording of the electrical current that travels in the heart. So when you look at this ECG, there are different what we call leads, which are basically like different cameras looking at the heart. So there are totally 12 leads. You can see here 1, 2, 3. Then you can see what's AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. So totally it's like 12 different cameras looking at the heart and looking at how electric current travels in the heart. So like we saw just earlier, what first happens is the current travels to the two upper chambers, which are the atria, and makes the atria to contract. So you can see that represented here by what is called as a P wave. This small blip is called as a P wave. And after that, we have the ventricles contracting, which results in this big, long upstroke, which is known as the QRS complex. And then the ventricles relax, which is what is represented by this deflection called the T wave. So you have a P wave before every single QRS. In other words, the atria will contract first, followed by the ventricular contraction. So atria contract first, followed by the ventricular contraction. Atria contract first, followed by the ventricular contraction. So this goes on uniformly in our heart all through our lives, which is how the heart is contracting and sending blood to the whole body. So it's important to know that these atria are contracting at a rate of around 70 to 90 beats every minute. So that is the basic usual heart rate at which somebody usually goes, and that rate is very, very important. So if the rate becomes too slow, then the body may not be getting enough blood, and that can happen if the current production is not adequate. So abnormal heart rhythms result in what are called as arrhythmias. Arrhythmias are abnormal heart rhythms. And these abnormal heart rhythms can either be fast abnormal rhythms or slow abnormal rhythms. It is the slow abnormal rhythms which are called bradyarrhythmias, which are the conditions for which pacemakers are put in. So these slow abnormal rhythms can either be due to a problem with current production or a problem with how current is transmitted through the heart, through the wiring system. So here, as you can see in this picture, in the previous one, we saw that there was the P wave before every QRS, and atrial contraction preceded the ventricular contraction. Now you can see, compared to the previous one, this is very slow. The deflections are very far away from each other as compared to earlier. And you also see that you're not seeing a very clear P wave that's happening before the QRS. So basically what has happened here is that you have what is called as a sick sinus syndrome, where there is a problem with current production. So current is being produced too slowly. The other problem that you can see is in this ECG, where you see that you have a P wave, then you have the QRS, that is, you have the atrial contraction followed by the ventricular contraction. Again, here you have atrial contraction, but there is no ventricular contraction. Again, here atrial contraction followed by ventricular contraction, and here there is atrial contraction with no ventricular contraction. So basically here there is a problem with how the current is being transmitted from the top chamber to the bottom chamber. There's a break in the wire. Sometimes the current is traveling, sometimes the current is not traveling. So this would be called as a type of an atrioventricular block, and this is something which can be serious. Here again you can see, you are seeing the P waves happening very regularly. That is, the top chambers are getting current and current is happening regularly there. But you see that every top chamber contraction is not followed by a bottom chamber contraction. After every P wave, we should have the QRS. That is, after every top chamber contraction, you should have the bottom chamber contracting. But we don't see that. In fact, we see the bottom chamber contracting regularly, but it is doing its contraction at its own rate. The top chamber is doing its contraction at its own rate, and they are not properly related to each other. So this again is due to a break in the wires between the top and the bottom chambers, which can again be a very serious problem in somebody. So when people have these kinds of problems, they don't come to you saying that they have an ECG problem. The doctor advises the ECG based on the symptoms of the patient, and on looking at the ECG, the doctor finds out what problem the patient has. So what are the symptoms that somebody who has a problem with the electrical system can present with? One of the commonest symptoms is fatigue, tiredness, lack of energy. So they will notice that compared to before, they are not able to do what they used to do. They are feeling tired or fatigued easily. The other problem that they can have is fainting. People can suddenly lose consciousness, and that can be a serious thing. Now, fainting can happen in a huge variety of circumstances. For example, somebody standing in the hot sun and has not drunk enough water can faint. Same way, an old person lying in bed gets up to go to the bathroom to pass urine in the night, he may faint. Now, these faintings are usually called vasovagal syncope, which is because of whatever blood that is there in the body collects in the legs when they go into an erect posture, and so their brain gets less blood, and that leads to them losing consciousness. This is not something that needs a pacemaker. This is vasovagal syncope, which needs a totally different kind of treatment, essentially encouraging the person to drink more water and changing their posture gradually. The old gentleman shouldn't suddenly get up and go to the washroom. Rather, he should sit down for some time in his bed and then slowly move, so that he gives his body enough time for the blood to circulate from his legs to his brain, and he doesn't have the fainting. However, there are some kinds of fainting which are serious. For example, if somebody is lying in bed and while lying in bed suddenly loses consciousness, that could be serious. Same way, if somebody is driving a two-wheeler or a car and while driving suddenly loses consciousness leading to an accident, that can be serious. So these kinds of fainting definitely needs to be brought to the attention of an electrophysiologist, which is an electrician of the heart, who would in turn do an ECG and look at what the problem is and see if there is a situation of either decreased current production or a problem with the wiring in the heart, either of which situations will need a pacemaker implantation. So we will now move on from there to what are the types of pacemakers and what are the features of pacemakers. So I will first show you what a pacemaker looks like, and this, as you can see, is an example of how a pacemaker looks. So this is a gadget which is called a pacemaker, and this pacemaker will, what I'm showing you is a dual chamber pacemaker. So there are two wires or two leads that can be connected to this device. This device has the battery which produces the electric current, and current from here will go to the heart. So I will now show you the two wires. This is one of the wires that you can see. Now, this wire will attach to the pacemaker. So for example, if this was the pacemaker, the wire will be connected to the pacemaker. It will go into the pacemaker. The other end of the wire will go into the heart. Now, as you can appreciate, this other end of the wire has got what is called tines. They have got like a small amount of projections on it, which you can see. These projections will get attached into the muscle of the heart. So this is called a tine lead. There is a different kind of lead, which is this, and this is called a screw-in lead. As you can see, it's got a screw at the end of it. So this screw is screwed into the heart. Between tine leads and screw-in leads, we always prefer screw-in leads because screw-in leads are easy to remove if in future there's a reason for the lead having to be removed from the patient, like if the patient develops an infection. So this is a screw-in lead. The screw is screwed into the heart muscle. This, on the contrary, is a tine lead where you can see there are small projections at the end of the lead, which is called a tine. And this tine is pushed into the heart muscle. And we generally don't prefer to use tine leads because they are difficult to extract if the patient needs an extraction later in life. And this is how a pacemaker looks like. This pacemaker battery is inserted into the person below the skin under the region of the pectoral region, which is just below the collarbone, or otherwise known as the clavicle. So this is a dual chamber pacemaker. I have fixed one lead inside it, and now you can see I can put another lead also inside it. So there's two leads connected into it. So because there are two leads connected into it, it's a dual chamber pacemaker. A single chamber pacemaker will have only one lead. A dual chamber pacemaker has two leads where one wire goes to the upper chamber, another wire goes to the lower chamber. Whereas a single chamber pacemaker will have only one lead which goes to the either the lower or the upper chamber, more often to the lower chamber. Coming back now to our discussion, we were talking about the types of pacemakers. So I said that you can have single chamber pacemakers and dual chamber pacemakers. So single chamber pacemakers have only one wire put in. We usually do not use single chamber pacemakers. Dual chamber pacemakers are recommended in most conditions because they have one wire in the upper chamber and another wire in the lower chamber. So they help to maintain the relationship between the upper and the lower chambers. As you know, the upper chamber will contract, send blood to the lower chamber, after which the lower chamber should contract and send blood to the body. So this coordination needs to be there, and that coordination is maintained well when you have a dual chamber pacemaker, which is why we usually advise dual chamber pacemakers for most of our patients. There are, however, certain conditions like atrial fibrillation where the top chamber is not in a normal rhythm, and the normal rhythm cannot be corrected by any means. In such a situation, there is no use in putting a dual chamber pacemaker, and a single chamber pacemaker will be sufficient. The other things that you need to be aware of when you put in a pacemaker is whether there is lifetime warranty or not. The lifetime warranty basically means that once the device has been put in to a given patient, then in future, when the battery gets over, the new battery is given free of cost by the company at no charge. So most people opt for lifetime warranty. It usually costs about 30,000 rupees more than going for it without a lifetime warranty. The advantage being that every time you need a battery change, the new battery is given free of cost. So that may be something that you may want to consider. However, if somebody is very elderly, like say 85-year-old, and you don't expect him to live more than about 8 to 10 years, then you may choose a pacemaker which doesn't have lifetime warranty. Similarly, if somebody's got a terminal cancer but needs a pacemaker and you don't expect him to live more than 8 to 10 years, that's another situation where you may think of using a pacemaker without a lifetime warranty. The other feature that you need to be aware of is MRI compatibility. The modern day pacemakers have this feature of MRI compatibility, which basically means that after a pacemaker is implanted, if the person needs an MRI scan, then the MRI scan can be done if the device and the leads are MRI compatible. When you have an MRI compatible device and you need an MRI scan, you need to go to your electrophysiologist who will use the computer and program your device in such a way that it can be ready for an MRI to be done. After the MRI is finished, you go back to your electrophysiologist and he again programs the settings back to what the original settings were. It is a useful addition and a useful feature. However, this also has to be looked in perspective as to what the patient's age is, what are the likelihood of him requiring an MRI before he finally leaves this world. Because MRI compatibility feature obviously comes at a higher price compared to devices which are not MRI compatible. You also need to be aware of the fact that most conditions can be diagnosed with a CT scan. And so it is not that an MRI is absolutely essential for all conditions. And also, what is the likelihood of somebody going to require an MRI due to an illness in future? So these are things that you need to keep in mind. If somebody happens to be very young and needs a pacemaker, it is advisable to put in an MRI compatible pacemaker because he is likely to live very many years in this world and may in future develop some condition which may need evaluation with an MRI. What are the other concerns that patients have when they are advised a pacemaker? The first thing is, what is the duration of the procedure? So usually the procedure takes 1.5 to 2 hours, but it's important for you to understand that the procedure has to be done in a very sterile, aseptic way so that there is no chance of any infection being introduced into the human body at the time of implantation of the pacemaker. So because of which, a lot of time and energy is spent by the hospital and the doctors to make the place extremely clean and sterile so that there is no bacteria that can enter into the patient's body. So this sterility process takes a long time, and as a result, the procedure can sometimes appear to be going for as long as 4 hours, though the actual procedure takes only about 1.5 to 2 hours. The rest of the time is often spent in ensuring sterility, making sure the place is clean, and following all the aseptic protocols. The other thing patients often ask is whether they'll be awake during the procedure. The pacemaker implantations are usually done with the patient awake. There is no need to do it with general anesthesia. We usually do it with local anesthesia, where a small injection is given in the area that is just below the clavicle, and that injection makes that area anesthetized. So the person will only feel as if the doctor is pressing over that area, but will not feel any sharp pain, except when that injection is given, and that injection will hurt as much as a mosquito bite does. So once that is being given, that area is anesthetized and the person will not feel any pain. Only that small area will be exposed. Everything else will be covered at the time of the procedure to prevent any infection from happening. So the patient can technically even speak to the doctor or even sing a song during the procedure. And some people prefer to just sleep, in which case the doctors give them some medicine so that they feel sleepy and they sleep during the procedure. The hospital stay is usually anywhere between 1 to 3 days. So if somebody is coming to Vellore for the procedure, they need to plan to be in Vellore for a total of about 4 days, which will cover everything, including admission, discharge, and the entire procedure. The costs of pacemakers again depends on whether it's single chamber, dual chamber, and whether it's MRI compatible. So if you go for one of the top end devices which has all the features available, is MRI compatible and is dual chamber, then your costs will usually be around 1,80,000 to 2 lakhs, depending on the kind of bed you choose in the hospital, whether you are choosing a private bed or a general bed. The patients usually are uncomfortable about having a pacemaker implanted and always want to know if there's another option. Like I said, if you've got a sick sinus syndrome or an AV block, there is no other option. You need to have a pacemaker, and if your doctor feels that is the treatment forwards, then there is no option. There is no medicine which can do the job of producing current or repairing the broken wire. So if you are advised a pacemaker, then you definitely need one, and there is no alternative option. Tablets cannot do the job of a pacemaker. Some people take tablets like Best or orsiprenilin, but there is no clinical trial in the world that shows that it helps, and it is not advisable to do the same. The other question is as to how urgently should a pacemaker be implanted. It basically depends on the kind of problem that you're having. If you have a sick sinus syndrome, that is a problem with current production, then it may be okay to wait for 1 to 2 months based on what your doctor suggests, in which case you can sort out if there's any emergency matter that needs to be settled at home before you get the implantation. On the contrary, if you have an AV block, then it is very serious and critical, and it is not advisable to wait, but have the implantation done as soon as possible. From there, we move on to the pacemaker implantation procedure itself. And as you can see, a small skin incision is made, a needle is inserted into the vein, and a wire is passed through that needle. Then over the wire, we put in a sheath. Once the sheath is in, we've got access into the venous system of the human body, which is like the highways inside the human body. And the lead, which I showed you earlier, is sent in through that sheath. The lead travels through the veins into the right atrium, the right ventricle, and goes into the heart muscle, where it is screwed into the heart muscle. Remember, I showed you the screw. So that lead is screwed into the heart muscle. Once this is done, the other end of the lead is attached to the pulse generator that I had shown you earlier. It's attached to the pulse generator, which will produce the electric current and send the current into the heart. So you can see there, the device is producing the current and the pulses go into the heart, making the heart to contract. So this is how basically a pacemaker works. So once a pacemaker is done and you look at the ECG will not look like a normal ECG because here the current is being produced by a battery from outside. So you will always see the reading on the ECG strip saying abnormal ECG. It is nothing to worry. It's just because it is not like how the normal current is produced. Here current is produced from a battery that is placed inside the skin, below the skin. So if you pay attention here to this ECG, you can clearly see that there is a electrical spike before the QRS complex. This one sharp line you can see here before every QRS complex. And that one sharp line is basically the battery producing the electric current, which is resulting in the heart muscle contracting, which causes this QRS complex. So we then move on as to what are the possible complications that can happen during a procedure. So any procedure can have a complication, and there are possible complications that can happen when you have a pacemaker implanted. Most of these complications are very, very rare. So there are some things that you don't really need to worry about, but at the same time, as somebody having an implantation, you need to be aware of it. So to put it in perspective, the chance of you having a misfortune happening when you travel from Calcutta to Vellore, which can be either a train accident or a plane accident, or somebody robbing your things that you're carrying with you, the chance of that happening is higher than the chance of you developing a complication after a pacemaker implantation. So what are the likely complications? The most common complication is what we call a hematoma formation. That's a collection of blood around the area where the operation was done. It can make the skin a little blackish in color, and there can be some swelling. This is quite rare, but it can happen. And it usually subsides on its own over some time, particularly with a pressure dressing that is done over it. The other complications, which are more serious, are actually very rare. So you can have what's called pneumothorax. So I showed you how the pacemaker procedure was done, where a needle is put into the vein. So sometimes the needle can poke the lung, and if it pokes the lung, which is like a balloon, can burst and air can come outside the balloon, which means air is inside the chest cavity. And in that situation, a tube needs to be put to remove that air, and that's called a pneumothorax. It's a rare thing, and it doesn't happen in most centers now, because most centers like our center no longer do an intrathoracic approach. We actually access the vein from outside the chest cavity with the needle. So there is absolutely no chance of this complication happening. The other rare complication is cardiac perforation. Like I showed you, we are putting a lead which has a screw at the end of it, and this screw can actually poke through the heart muscle and make a hole in it, leading to a perforation needing a surgery. to close the hole. That is again very, very rare. Usually happens in elderly ladies, but never happens in experienced centers. So it's though it's a complication that you would read about in the books, it's an extremely rare complication. Rarely you can have what's called diaphragmatic pacing, where the wire is put in a place where you have a nerve called the phrenic nerve, which supplies the diaphragm, which is a muscle that separates the chest from the abdomen. And when the current comes to that muscle, it will make the muscle contract, which results in hiccups. So the patient can have hiccups after the procedure, which can be due to this complication. Again, it is very rare because when one does the procedure itself, one knows if he is going to be capturing the diaphragm or not, and he will change the position of the lead during the procedure. So this doesn't really happen. The complication that we are most worried about is infection. Infection is something that can happen if the procedure is done in a careless way and not in a proper aseptic way. Precautions were not properly adhered to, and bacteria managed to enter into the wound. That is a complication that we don't wish to have at all, and we do everything that we can to prevent that from happening, which is why the procedure takes a long time, because we do a lot of sterility procedures and protocols to prevent infection from happening. Our risks of infection in our center are as low as 1 in 1,000, which is much better than what is seen in even most of the developed countries. Now, the problem with infection is that if an infection occurred, then the entire machine and the wires have to be removed. You cannot treat an infection by just giving antibiotics. The machine and wires has to be removed along with antibiotics, and then a reimplantation has to be done subsequently. So it's something that you don't want to happen at all, and we take all precautions. It's also important for patients to be aware that if they have a tooth infection, a skin infection, or a urinary infection where they have burning when they pass urine, these things have to be immediately addressed and treated. So patient has a pacemaker, goes home, and after 2 or 3 months later develops a tooth infection or a urinary infection or a skin infection, but ignores it, doesn't take treatment for it, then the bacteria from those places can spread to the machine and lead to a machine in the device. So very important for patients who have pacemaker implanted to treat any infection that they have immediately and to take it seriously and not to delay and postpone. So you have a tooth infection, you take a painkiller, the pain goes off, the infection is still there, but you think all is well because you don't have any pain. Then the bacteria from that tooth which is infected can spread to the pacemaker and cause a pacemaker infection. So it's very important for you to treat your infection seriously, meet your doctor immediately and get that addressed so that you don't develop a pacemaker infection secondary to another infection like a tooth infection, a skin infection, or a urinary infection. The last complication is again not a common complication. It's what we call heart failure, and that can happen because of the place where the wire is placed in the heart. So like I showed you, the pacemaker wire is screwed into the heart muscle, and it is basically how we human beings are doing it, which is not the same as how God did it. So when I showed you in the initial picture, I showed how current travels down all the wires of the heart so that every part of the heart gets current at the same time. But when we human beings put a wire to give current to the heart, we cannot replicate identically to what God does. And so current goes to some parts of the heart early and some parts of the heart late. As a result of this, about 10 people in every 100 people who have a pacemaker implanted can have their hearts becoming weak over time. So this doesn't happen to the majority of people, but there's a small minority, 10 out of 100, whose hearts can become weak over time. So the modern day implants are all done, which is called as conduction system pacing. I will come to that later in my talk, which helps prevent this thing from happening. Moving on from there, what are the things that has to be done after the pacemaker is implanted? What is the care that the patient has to be taking after that? The first thing is to avoid abduction of the arm, which is basically lifting the arm above the shoulder. So for the first 6 weeks, we advise our patients not to lift their arms above the shoulder unnecessarily. If there's an absolute necessity, like having to wear a banyan or having to take something from a higher level, then it may be okay. But doing this arm abduction repeatedly like a yoga may not be a good idea for the first 6 weeks after the procedure. It doesn't mean that the patient shouldn't be moving their arm. They definitely have to move their arm adequately so that the area doesn't become stiff and your post pacemaker care nurse would explain these exercises to you. The other thing is with regards to driving, we advise people to avoid driving for the first 6 weeks, again to limit the amount of arm movement, and we do that so that the wire is properly fixed into the heart muscle and does not get displaced. The next question often asked is amount of weight that somebody can lift. We generally advise them to avoid lifting weights on the side where the pacemaker was done. So if the implantation was done on the left side, then we would advise them not to lift weights on the left arm, at least for the first 6 weeks, after which they can start lifting weights like normal. With regards to taking a bath, you can take a bath immediately after the procedure. Please put a plastic covering over the site of the procedure and take a bath so that there is no water falling on the site where the procedure was done. After 2 days, the doctor who has done your procedure will change the dressing, look at the wound, and if the wound has healed well, which is what is the result almost always, then there is no need for you to worry anymore. You can take a normal bath, put soap and water over the wound, and wipe the area dry. Don't wipe it forcefully, just gently pad wipe the area and keep it dry. The other question people usually ask is about sleeping on the side where the operation was done. You can sleep on that side, but you will probably feel a little uncomfortable because this machine has been put in. For some time, you may feel a little bit as if there's a small weight inside, but nothing to worry. That sensation will go off in a short while and you will be able to sleep on that side. People are often worried whether they will be able to do their normal activities after the pacemaker implantation. Nothing to worry. People have actually climbed the Everest and even won Olympic gold medals after pacemaker implantation. So there is no restriction in those terms. With regards to suture removal, we usually use self-absorbable sutures. So you don't need to worry about any suture removal. Whatever is there will automatically get absorbed and dissolved. There is no specific diet that has to be followed after a pacemaker has been implanted. So you can have whatever diet based on your other conditions. For example, if you're a diabetic, you'll have to follow a diabetic diet. If you're a hypertensive, you'll have to have less salt in your diet and so on. But pacemaker per se has got no dietary restrictions associated with it. Some of the concerns are what are the things that have to be avoided. People often think that they'll have to avoid equipment in the kitchen like the grinder, mixie. There's nothing like that. You can use your grinder, use your mixie. You can press the switch on. You can put the switch off. That will not affect you in any way. People are also worried about lightning. You don't have to worry about that at all. There's no risk of walking. The chance of lightning affecting somebody with a pacemaker is equal to the chance of it affecting somebody without a pacemaker. So having a pacemaker does not put you at any increased risk. What somebody who's had a pacemaker cannot do is welding. So if welding is your profession, where you sort of melt two pieces of iron and join them together, then that has to be avoided. You cannot do welding once you have a pacemaker implanted. The other thing is special types of physiotherapy, which involves electric current. It's called transcutaneous electrical nerve stimulation. So whenever they use electric current to do any physiotherapy, that has to be avoided once you have a pacemaker that has been implanted. Also, when people have a pacemaker and subsequently go in for some other surgery, the surgeons use something called electric cautery to prevent bleeding. This electric cautery cannot be used if you had a pacemaker implantation. However, there are different types of electric cautery. There's bipolar and unipolar, and it is advisable to use a bipolar cautery rather than a unipolar cautery. And again, if the area of surgery is more than 6 inches away from where the device is located, then it may be safe to use a bipolar electric cautery. Patients who have had a pacemaker implantation should avoid high tension electric wires. So this is not the regular electric wires that are there in the streets, which are supplying electric current to the street lighting, not those kind of wires. We're talking about high tension electric wires, which sort of carry the current that is coming from the grid to be supplied to an entire city. So when you have that kind of setup, then you shouldn't be within 6 meters of that. You should. The other common question asked is about the usage of mobile phones. You can definitely use mobile phones, but use it on the other ear. So if you've got a pacemaker on the left side, use your mobile phone on the right ear. That would be advisable. The other thing to remember is that you keep your mobile phone in your pant pocket and not in your shirt pocket. The travel, you can do air travel. There should be no problem. Particularly, like I said, we do all our punctures extrathoracically. So the chance of a pneumothorax complication is very low, so there should be no issues with air travel. In the airport, when you walk through the metal detector, it is going to alarm. because you have a metal inside your body, which is the pacemaker. Nothing to worry again as far as you are concerned. However, it is a concern for the security officials because of the alarm, and they may be worried thinking you're a terrorist. So it's important for you to carry your pacemaker identification card or your discharge summary to show it to them. And once they see that, then they will understand that you are actually carrying a medical device within you, which is why that sound came. But walking through the metal detector is not going to damage your pacemaker in any way, so you don't need to worry about that. We'll now move on from there to follow-up. Once a pacemaker has been implanted, we advise our patients to come back and see us anywhere between 6 weeks and 3 months, by which time the wire would be properly fixed into the heart muscle. And once the wire is fixed into the heart muscle, we will know what the various parameters as far as the machine is concerned in terms of how much current is being used, what frequency, what voltage, all these things. So these are things which are important for the doctor to see and assess. And so it would be good if the patient can come within 6 weeks to 3 months. For those patients who are from far away, we ask them to come 6 months after the procedure. The battery life of these pacemakers depends upon the usage. The more you use, the quicker the battery will drain. But most pacemaker batteries last for at least 8 years. So that's sort of the time at which you are likely to need a battery change. And if you actually had a lifetime warranty implanted device, then your battery change is technically, you don't need to pay for the new battery. The other question is with regards to remote monitoring. So nowadays there's a small gadget which is like the size of a mobile phone, which you can purchase. And if you have that gadget with you, then you can transmit the information from your pacemaker to the hospital, and the doctor who is sitting very, very far away. This can be transmitted from across the globe. So even if you're sitting in USA, you can transmit your information to a doctor sitting in India, and the doctor can look at it and know how your pacemaker is functioning. The advantage of this is that it avoids the need for you to travel to the hospital. So you had your pacemaker done and you're a busy person, you can't come back in 3 months or 6 months, then you could sort of transmit your data using this gadget, and the doctor can sort of see that and advise whether it is important for you to visit him again or you don't need to visit him based on the data that you have transmitted. So normally we tell our patients to come once a year for a checkup or once in 2 years. But if you have a remote monitoring device and you're able to transmit the data to the doctor, then those visits can be made less frequent. On the visit to the hospital, the doctor will be able to tell you as to when you need to have your battery changed. So like I said, currently in our hospital, we do what is called conduction system pacing. This is basically done to prevent that complication of heart failure. I told you that about 10 people in every 100 can develop heart failure over the years because of the wire and where it is fixed. So the wire, as we said, the pacemaker wire is screwed into the heart muscle. So it's screwed somewhere into the heart muscle, which means current first goes to that part of the heart muscle and from there travels to the rest of the heart muscle. It is not like how God made it, where current came down the normal wire and traveled to every point at the same time. So that is the reason why there is lack of synchrony, and that dysynchrony can make the heart weak over time. So to avoid that from happening, we nowadays do what is called conduction system pacing, where we put the wire and screw it into the normal wire that God has given us with. And that way, the current that is brought from the machine is sent into where these wires are located to help the various parts of the heart to contract at the same time. So this is called conduction system pacing, and we hope that this will help preventing patients from developing heart failure as a complication from pacemaker implantation, which is a rare complication, but all the same, something that we would like to avoid as we make things better. So with that, I have covered all the issues with regards to a pacemaker implantation, and I would be happy to clear any doubts that you may have over the email. You can send in your emails to cardio.ep@cmcvellore.ac.in, and we could address your concerns. Alternatively, you could check out on our website cardiology.ep@cmcvellore.com, which has the necessary information on pacemaker implantation. Thank you.